So let me thank Rima seriously, and also the panel members. I think this is a very important and very interesting discussion. So let's have a little cognitive discussion now amongst the roundtable members, and let's have some fun with the cognitive discussion, and let's continue it at dinner should we not finish it here. But I would like each roundtable member, we do this each time, and I think it's an important exercise because we take the reflections and use it for future either writings or programs. Let's have each of the roundtable members identify one or two, and Cindy, I'm going to include you, Cindy, I'm going to include you as we go around the room, to identify one or two key points that you glean from today's workshop. We have time, so we can spend a few minutes on each roundtable member. Keep the comments short and to the point, but if you feel that those points have been made, there's no reason for you to do it again, that's fine also. We'll get you up at dinner. So let me start with Terry Ann Parnell, and I'll just go down that row and come around this way and just before Lila. So Terry?
Thank you, yes. So I just wanted to say that I thought it was a wonderful day, better than I even anticipated, honestly. I enjoyed very much beginning the day with the personal landscape and then kind of bookending it with the personal reflection panel at the end. And that center core being the community and family landscape and health system landscape. Key points that I took away is the role of advocacy, empathy, building relationships, broadening our view with health literacy and the elderly to always incorporate the social determinants of health. And I almost think they're more important than some of the medical indicators that we're always looking at. They are more important. And when one of the speakers talked about the 3 generations, I would just challenge you to say that I think many people have 4 generations now, and we have such wonderful opportunities to learn from each other and to really continue to do a better job at this moving forward.
All right, this is my first comment, so I got to figure out how to do it. But it's hard to get lawyers to stop talking. So I'll just try and stay focused.
We do have tape, though.
Okay, we do have tape. There was really a couple things. The first thing, from that Mary Ann mentioned was really striking to me because I'm an only child myself, in thinking about the caregiving that I'm going to be giving to my parents. Thankfully, my dad's still around, but my mother just got her second bout of cancer, and so we still have that caregiving network that's there. But that's what really struck me, is not that just I'll be the caregiver at some point for my last parent, but the fact that we really, I heard themes of that. We really need caregivers for caregivers. That
Yes.
we not only need to train the caregivers, but we also kind of need to train the family, because there is this dynamic. The legal side of me, thinks of the elder abuse, and the non-legal side of me thinks of, just that everybody's going to be a caregiver at some point in their life for somebody, whether they're the older adults or younger, babies or something like that. But we all don't know how to do this. I'm good at some things and horrible at others. And so that I was really interested to hear about the caregiving boot camp that was mentioned. And I think that's something where we can use that not only to train people about some of the, the healthcare roles, but also their responsibilities and their obligations for being a caregiver. So in the legal world, we have guardianships, and conservationships, and there's some protections at the state level to make sure you're doing it well, but not at the caregiver level when the person still has their mental capacity. So that seems to be to me to be a good way of something to focus in on. Is that caregiver training, which can also again obviously be given to patients because they're going to be caregivers perhaps of others in their life as well. But then the other factor that really struck me with Dr. Thomas was trust. So how do we combine this trust the trust needed in the healthcare system with caregiving? So how would we do that? It's key. So would it mean the barbershop training of caregivers, not just patients and treating patients, but as a way to kind of connect with the caregivers and teach them about their rights and responsibilities. Those are some of the main things. And then the one thing I kept hearing throughout, which obviously because of my filter of legal, is just how the medical and legal world, particularly in the elder community, really intersect. You can't really talk about advanced care planning without thinking about some of the the issues with the advanced directives and estate planning and how you handle that as well. So that was really interesting to me.
Thank you. Steve?
Yeah, thanks. And today was really very interesting. There was a new piece, and that was the reclassification of older adults. And I wasn't aware that there was different classifications, young old, middle old, old. But that makes a whole lot of sense. And that will help inform some research. Also, I got reinforced that it's more than just providing information to people. We can do that lots of ways. We push it out. We burden them to death. I'm sorry, that's a terrible pun. It's making sure that people really understand and that they can use the information, and that goes across all disciplines in providing care. So that's two pieces. Thank you.
Christina?
Hello. So, like everybody else, I sort of am having a lot of sort of feelings about today. So much of this is personal. So I'm echoing what Chris said about the only child thing. Being a caregiver of a parent and a child, a couple of kids at the same time, and sitting here in this room thinking, gosh, I'm supposed to be here for work, but this is really sort of speaking to me as a person right now and what I'm experiencing. And the funny thing is, sort of across the day at lunch and every break, I experienced that everybody else is sort of in that same boat. We're all sort of struggling with what does this mean for me as a person, and then what does this mean for our work, and how we sort of situate this in the big life problems, which just tells me that we're in the right spot, that this matters to everybody all the time, and we've got to get serious about this and do more than we're doing. So that's important. So it crosses this personal and professional. The comments on resilience and adaptability really cross that area of personal and professional for me. And I was really happy to hear someone talk about that. I think it's so easy to get caught up in the burdens like we do in health literacy when we think about the deficits, that this idea that people are remarkably resilient and adaptable and they're able to do so much, and figuring out how to help them be their best selves and do this work is sort of what we're all here for. Also, these cultural components, so trust, community. We've talked about all these topics over the course of the last 2 years or so on the roundtable, but they keep sort of popping up in these interesting places. So that's sort of cool. Also that it's multifaceted. I mean, we're starting to have sort of this debate here in the group, for example, about like cognitive decline and how this fits. And I'm struck by why is this either or, right? So we can have problems with how we use language and what the words mean and how we practice, and also the reality that as we age, our brains change and our bodies change and we have illnesses, and we have to think differently about what we do with our health and how it affects the choices we make. That's reality. And then the final thing I want to say is the interventions are interesting to me. So I think, back in the beginning, I asked Amy this morning about the interventions that were promising, and she really sort of took us back to basics and started to talk about sort of slowing down and teach back and provider communications. And I think that's true and relevant. But as we went the rest of the way through the day, we're starting to talk more about these community-based interventions, meeting people where they are. Other interventions that are often connected to social work. So, how do we treat the whole person? That's really what we're talking about, is there's a real person here and they have something that matters to them and they want to be treated in a certain way and they want to be heard and they want to be seen. And we can do all of that all the time if we sort of bring our best selves to practice and we practice with them what that is. And I think Mary Ann did a really nice job over the course of the day of reminding us that people know what they want and they know what they need and they want to be partners in care, and they have the capacity to do that over and over again. And we don't always let them, but when we let them, they can do it. Not even when we let them. When we all show up together and sort of recognize humanity in all kinds of spaces. And so that's a really cool reminder, and I thought it was awesome.
Okay, I think the point that I garnered from today was the heterogeneity of the aging process. And I think that I took away that I could look at this from the individual health systems of the community. When I look at it from the individual, I can see that we're talking about making sure people continue to have a sense of purpose in their life. And I think that was compelling to make sure, remind ourselves. The health systems and the distrust issue resonated with me because I see that and live it every day, recognizing that the question I guess I have, we have to explore and do a deeper dive. Can health literacy by itself get us beyond some of that distrust? And I'm still wrestling with that in my mind. I do know, and I have a little hope when it comes to things that's happening in the healthcare academic setting when it comes to building tracks and opportunity for us to look at character when professionals go into the health field. And I see more younger people as I interview them coming into medicine, understanding their role as an advocate. So it gives me hope. I think I was responding to Lisa's comment. It gives me hope that there is a generation of young people who see that their job is beyond just doing tests and giving a diagnosis. They can connect to the whole person. And then the last but not least, the disparities issue that I see in communities reminds me that we have to focus on how do we build the village that Mary Ann talks about. She has the village that many of the population that I serve have lost the village. And so neighborhood cohesion becomes a critical piece of us getting people back to health.
Yes. So I learned so much today, as I do every workshop. So thank you to everyone. And one of the things I was disappointed to learn was that there was this category of old and older and still really yet older than that. And and I'm actually hoping that maybe this next generation that Lisa and Ernestine have reminded us that we should have the confidence in, because this is a generation, right, that doesn't see race, right? So I am hoping that they also, don't see age when they're starting to take care of me, and so I have a lot of confidence in this generation that they're going to have our conversations be different. How's that? And then I also just, as always, have been reinforced that putting the patient, putting the individual at the center of everything that we do and not designing without them, but co-creating with them is really where we can get to effective solutions for everyone. And I guess the last thing that I would leave the roundtable with today is that I'm excited to meet Lisa and know that even though my voice will not be here, I know that the voice of that individual and that consumer is going to be heard loudly. So.
It's so much easier to go 7th than like 27th. So thank you, Bernie, for starting there. So Katina said you can kind of predict what we're going to say, so you can probably predict this one. But a lot of our time is spent on the focus around doctor and patient. And today, which was wonderful, also around the role of the community and programs like CARE and others. But there are others involved in supporting the patients outside of a doctor's office. And so I just want to reiterate, the important opportunity that others outside of that, including insurers, pharmaceutical companies, pharmacists, civil organizations also have in this conversation, and the opportunity and obligation that we have to think about it. I love the stage 4 translating to action. And one of the things that people mentioned offhandedly, but was clearly important to many of us, was diversity in clinical trials. And a lot of the conversations there have focused around race and ethnicity and gender kind of secondarily, but it's really important to understand how medicines work differently across ages. And so it feels to me like we should really work together to look at the project collaboratively, and specifically with health literacy as a potential way to address trust issues by being trustworthy. And finally, I know there is a lot of energy right now around patient-focused drug development and getting the input of the patients into the drug development process. And I think it's really, today was a great reminder to also include the perspective of the caregiver in all of this as well. So thank you.
So, hello, this is my first roundtable, and Chris took my comment, but just kidding. And Katina, what I was really reflecting on today was how these issues directly affect me, and I couldn't help but think about my young, old parents and how they're beginning to have health issues and interact with the healthcare system. And just thinking about also the complexity of these health issues as well as the complexity of the health system and increased demand the system has on them. And I appreciate the attention to racism, which is also what my family experiences, and rurality, living in rural areas, and how that even makes the context more complex. But what also resonated with me was the attention to trust-building relationships and finding places where people feel safe and comfortable, which can then help mitigate the complexities.
Great. Okay, so a couple of things resonated with me, but I'm just going to mention two highlights. First of all, one of the things I thought was important to learn was that when we talk about patient-centered care, we always think about it. There's a lot of things that go into it, but I think you can't do patient-centered care without health literacy. And I remember Yolanda saying something about a patient is the expert of their own health, and how do we teach them to ask the right questions? And so it just made me realize that, yes, we need to be able to communicate information in the way they can understand, but how do we build confidence that they can ask the right questions? Like Lisa was saying, they can talk to their provider, they can actually communicate, not just because it's easy for them to talk about, but do they even know the right questions to talk about and to ask their providers? So I thought, that was important for me to learn. And I think the other thing was something that Dr. Thomas talked about, which is the connection to the community. It said something that was really, that's stuck in my mind now. He said, when the provider goes to the community, they do talk in health literate terms. It's interesting, by just changing the setting that you practice and just going out of the doctor's office, all of a sudden you realize like, hey, I have to talk in the way that they can understand. So just something that I think is important for me, not just to take back, but it's important for us to know, even as we go back, start teaching pharmacy students some of these things and go back to the schools also, is to let them realize that sometimes you just need to get out of the doctor's office, you just need to get out of your provider office. And then health literacy then becomes very important and significant in your communication. Yes, exactly.
So, speaking of personal stories, I was surprised that your mother and I are the same age, Kim. But, we do grow older. I enjoyed hearing the voice of new people and learning from them. And I kept writing down resources and sending them off to people all day about connection.
Which one are you talking to?
Oh, I'm not being still. I enjoyed hearing from new people, and I was saying I was sending people information about resources that I learned from them all day that was connecting. But I think for me, as a health literacy person who's been doing research in this for years, I've been aware of, when we're working with people, about the complexity of self-management and their skill sets. But what I was aware of is health technology is here to stay. Technology is exploding, and it's not leaving healthcare, and we've got to make it more user-friendly for people like me. I mean, I hate portals and I hate passwords, and you just have to make it a little more user-friendly for me, and that's possible. But that's not my. I have the skill set to make certain things easier. I don't think I have the skill set to make technology easier, though.
No, the one funny comment I was going to say, following up on a comment that Rima made, I do a lot of work in technology in how you can be incorporated into help patients self-manage, and we had a grant with NIH, and the program officer, before they gave us funding, was trying to wrestle with the fact that we were trying to use technologies to assist an older adult population reduce the complexity in their care. And they asked me, is this for future elderly? Which I kind of thought that was the oddest term, future elderly. I'm going, I hope we're all future elderly if we're lucky, and which is to Ruma's point. But you know, it gets to a comment that I think, to reiterate what Terry said, we do, I think, cut off the possibilities of certain opportunities to work with tools that could be beneficial, and we make assumptions, you know, and granted there's truth to some of them in terms of what might possibly work. I do think some of the conversation that you know, makes me think of when we had in the National Academies, when we had the Health Literacy Conference here a few years back, and we had an aging panel, and Denise Park and Sarah Sajan, people have done a lot of work. And again, I think a lot of that wasn't covered here in this meeting, was how do you really harness some of these tools and acclimate some of these new platforms for older adults? Because a lot of this, I think this conversation focused on the community is fantastic. It's been very educational for me. A lot of what my research is focused on is how do you deal with the fact that we still have a looming problem of a healthcare system that is dealing with the geriatric shortage, that maybe a lot of these patients are dealing, that you're seeing how well is our healthcare system really acclimated and prepared to deal with a very large trend of primary care-based patients who are coming in with multiple chronic conditions that don't necessarily, and also practices that may not be ready to pull the trigger and make connections to the community, to the many resources that we've heard about today. So from that end of it, I think this has been really, really helpful to hear the other side of the picture of what is out there, but I still wish we could have talked a bit more about really fixing what is an overly complicated healthcare system for a population that's very much at risk for some of the things we heard about today.
Well, as a geriatrician, a lot of what was said today was music to my ears. But one of the things that truly concerns me is that a lot of our geriatric patients in the U.S. don't receive standard of care because they're older and don't need it, supposedly. But even when attempts are made to give them the appropriate care, the training in geriatric medicine is generally poor, and people struggle with giving appropriate care for many of the geriatric syndromes. So we have a context in which the quality of care is poor, and then you layer on top of that low health literacy. And it's really a distressing, concerning situation. So I'm quite thrilled that this group has highlighted some of the issues, because we have a lot of work to do. The other thing that I think is really very important is the connection that was made today in terms of the community-based services. Because the health system, just as the IOM noticed or noted in the early report on health literacy, the health system is not going to be able to bear the major burden of the health literacy, low health literacy issues. It's going to have to be in the community, a lot of it. And the networks that we have to support older adults, which albeit are not well funded, those are systems that can easily be utilized, and if we can get more funding, to address some of the low health literacy issues. So I think there's lots of reason for hope, and I'm so happy that this is being addressed. So thank you.
Thank you. First, again, my compliments to the program planning committee. It's been said, but bears repeating, so that so much of our conversations today were from about people's experiences, our own experiences, and then relating towards the evidence base, the research, and our work through that. And I think that made it really memorable, made it extraordinarily engaging day throughout, and also something that we'll continue to take with us. There's an entire cottage industry that's popped up about having conferences in healthcare, from patient-centered or patient engagement and all that stuff. So, and people pay big bucks to go. So, it speaks well towards a meeting like today where that's really involved, and where we had that type of focus. Second thought was around, again, on the technological development and the way that gap has the potential to increase with large-scale negative consequences. Mike is in his research, so not to frame it, but is working on the big systems components. I see the parts of kind of like the one-offs of in there, where potentially we can increasingly view older adults as a distinct user group with their own needs. And the way I would go with that is, if we think about your phone in your pocket, that's largely been developed with the idea in mind of a user, of a person that has no capabilities, that comes in, or there's no experience on it, or has technological experience. And that's very different from a user where you may have a lot of established biases and negative transfer. So that there are ways that we can have an increased impact. Health literacy, Tara, to your point, of how you can do that, your work and your career's research is directly applicable in that, because in many ways, for older adults, their experience in coming to technology is very similar to someone's experience of coming as an immigrant. I mean, it's around like things. No, but I mean, it's around things of language and culture and access and understanding, and those points of. So if we can build those in by design, which is a process through the technology is already intrinsic, then there's a lot of applicability of where health literacy can have design differences and address some of those systemic issues. Thank you.
Hello, thank you. It's a pleasure to have this be my first meeting, because certainly a very interesting topic. And again, I echo the kudos to the planning committee for this. In terms of my comments, I think one was also what struck me was the discussion of heterogeneity within the aging population. Specifically, though, and I was able to reflect a little bit at lunch with those I was sitting around, but the evolution of independence and what that means as people age. And in terms of questions that was asked earlier, but also what is the definition of family and what is the definition of community? And that's certainly going to differ depending on who it is that you talk to and how that relates to the work that we're doing. The other piece that was just briefly mentioned that I've been just rattling my brain about all day, and Dr. Thomas had mentioned the use of plain language and the history and legacy. His example was of the Tuskegee study, but how we can use plain language for good or we can use it for not. And so what that means in terms of what we do in our training, I am in a school, so thinking about how it is that we're training the health providers as they come through, thinking about the biases that come along with race and culture and age, and what that means in terms of how we're teaching these best practices within health literacy and what that means for plain language. And how those biases that we have to acknowledge that do exist, how that affects how they actually implement and practice these health literacy practices as it relates to plain language. So that's been traveling through my mind, especially as it does relate to the older adult population. I'm here kind of staying also in Richmond with my grandmother now, and just seeing her decline is really new for me and a little bit traumatizing on a personal level, as people have been saying. So all of this is very fresh and very new, and there's been a lot of questions that have been raised for me, both personally and professionally, in terms of how we're teaching this, at least at the dental school at Tufts. So thank you all.
So for me, every time we have one of these workshops, I always try to just bring this back to these, my own core concepts of health literacy, and among the, they said 16 different definitions of health literacy. The one that I always try to use is health literacy is really about removing barriers and leveling the playing field and being as inclusive as possible. So in that vein, one of the things that struck me today was this, it was mentioned a couple of times, is this issue of social isolation. And we see this quite a bit. And it may not be directly, specifically in the pigeonhole of healthcare, but I think it's really part and parcel of everything that we do. And so that sort of leads me to this, this observation that, caring for older adults is not just completely and solely the responsibility of the healthcare system. It's really about community. And I know a few of you have already mentioned that, and I think that's a very, very important concept. It's certainly key to a lot of the things that we're doing as well. I think in the social isolation piece, these are these issues of just conversation and the lack of conversation, just being asked, that notion of mentorship and passing along knowledge, all of those sorts of pieces. That's all about inclusion, and it's all about continued integration. And when we talk about age is really just another way to look at people. I mean, when we say, oh, okay, well, once you're 65, you're an older adult. That's sort of a label that we use, and I would just caution all of us to make sure we remember age is just that one thing. There are people who are elderly and there's lots of other ways for us to look at people. You don't cross a magic barrier on, the midnight of your, before your 65th birthday, or unfortunately now 55 or whatever, 50, whatever the new barrier is. But we are many, many things to ourselves, to our, we are members of communities, we are members of groups. And I think it's just important for us to remember that and to not use the labels and the pigeonholes, but just to be as inclusive as possible. And as we refer and think about people, even though they are a certain age, that's just one way to look at people. There's many, many other aspects of them, and they have many other needs, and we need to make sure we're aware and we attend to those needs.
Thank you all for a very interesting day today. I'm so excited to be here. I've been thinking about health literacy for 20 years. The most striking thing I heard today, and I would say shocking even, is the need for disruption in the long-term care industry. And some of you know that I've spent years working at Medicaid, and I always think about disparities because of the population we're serving, but I never really think about disparities outside of the Medicaid population in the same way. And this discussion to me today really highlighted the need. We're at a time when there's disruption everywhere. And I don't see a lot of people trying to disrupt this space in long-term care. So I was a little bit, I was very surprised by that, actually. Also, I have a concern that the technology and this movement in technology is exacerbating health disparities. And I think about that a lot when I talk to my father, who's had a flip phone forever. And his birthday was March 4th. And he called me and said, and he never asked for anything. And he asked for a smartphone. And I about fell off the chair. And I wanted to know why. Why all of a sudden, what's happening? And he said, well, I think I'm missing out. So I think the social isolation is a health issue. And I was feeling that from my father, that he feels very disconnected from the rest of us because he knows that we're on group chats and we're sending pictures to each other. And so now he's asking for a smartphone. Well, I got it for him. And he called me and he said, this phone is giving me a headache. Because he's frustrated now because he had to get rid of his flip phone. And now he's, I think, getting depressed. So the technology is just, I think there's a lot there that we still need to understand about technology in this population particularly. And then related to that, I'll just react to a comment someone made about, I think the question was, can health literacy address the trust issues? I think it absolutely can, because we need to democratize health information. It's been we hold this information like it's sacred. And the reason for the distrust, in my experience, is that we don't share the information. And we don't share it in a way that people can use it and understand it. I mean, that's why we're here. So I think that we absolutely can. Oh, right. What's your name? Ernestine, yes. So thank you for that question. To a point. It has to be accompanied by the human touch. We can't divorce those two. So there's a balance.
I'm very, very interested in something that we did not address. I'm not criticizing the planning committee because I was on the planning committee. But one of the things that I'm very interested in, and you might call it a morbid interest, is the issue of death and dying. And there are a number of things that have become very popular. So via the New York Times, death cafes, people meeting in cafes in small towns all over America to talk about death and dying. A new app that came out that gives you a signal 4 times a day at different times saying, you will die. I tried it out. It was very interesting. But when we talk about getting old, and when we talked about, excuse me? You said one more thing about it. I meant when it said you will die. You will die. You can opt, it's just a message that comes on your phone. Well, it's supposed to, as it was written up in the New York Times, it's supposed to remind you to value the experience of the here and now with a reminder that you're going to die, that this is not forever. And so it's supposed to enhance your appreciation. And if you choose to, it gives you a quote. I found the quotes kind of mundane, not very interesting. My response, it was okay. It became a little humorous after a while. My husband did keep the app. I got rid of it because my neighbor, who's a good friend, was terribly upset by it. And she bribed me into getting it off my phone. But it was interesting. It didn't necessarily achieve its purpose of bringing about that philosophical moment in my life. I can bring that about in other ways. But I thought it was interesting. I am very interested in the death cafes of people getting together and talking about the process of death and dying, because it's a silence. And unless we break that silence, it becomes a no-no topic that we can't bring up with people because of a fear of offense or other reasons. So it is an interest of mine. I will continue that interest. I'm doing a lot of reading. But I miss that in the discussion here because that is part of the aging process. One is aging and one is moving towards death. And I think that we need some way of making it easier in our society to talk about that. And health literacy, which has a role in focusing on dignified conversation, dignified in the sense that two people are talking the same language to each other. People are feeling free to ask questions and have the words to ask those questions. I think we have to help our society develop the words to have those conversations. So that was the thing that was on my mind that was a bit missed.
What's the name of the app? I'll find out. I don't remember, but I'll find out. Thanks, Bernie, for the opportunity. I heard some themes that are very familiar to us that we've, focused and done a lot of work independently and collectively over the years. We heard about sort of the universality of limited health literacy, about the caregiver who panicked and wasn't functioning at her best. We heard about the multiple and exacerbated navigation challenges that people face when they get multiple chronic conditions, which is very common among the elderly. And we all sort of thought about our own mortality, our parents, our grandparents. And I, found myself thinking about my father and the fact that I don't know what kind of electric bed to get him, and I haven't, couldn't figure out some things, but I'll get some help with that. And I really kind of thought, that's what my friends and I call a first world problem. I mean, we have the money to buy the bed. I can, find the geriatric care manager that can advise me which one to get, And we haven't really focused in on some of the more acute problems with this population, which despite nearly universal health coverage with Medicare, that there are many elderly who are facing social determinants of health problems. And I'm particularly focused on the fact that we didn't really talk about housing per se as a part of this, because in the elderly, the housing and the health care become overlapping and almost indistinguishable at the point where you can't be independent and need support, and how those fit together. And I did expect to hear something about the dual eligible, those who are eligible for both Medicare and Medicaid, maybe even some throwbacks to social HMOs or the new Medicaring community that Joanne Lynn has been championing, or other models of, I guess one could call it disruptive innovation, but of really changing how we think about people live and are housed and needs are met across the continuum. And I think with Michael Pasch-Orlow not here, we owe a debt to Stephen Thomas, who kind of, encouraged our moral outrage that, as a society, if we're judging our society by how we treat the most vulnerable, then looking at the elderly as a population, and particularly those at the more disadvantaged spectrum, we're not doing very well. So taking all of that back to health literacy, though, I really wanted to think about, as working for the Agency for Healthcare Research and Quality, what a takeaway that I could carry with me and perhaps think about the next steps. And I was very struck by having seen on the screen the caregiver quote that said, why are they talking to him? He doesn't understand anything. I'm the one who makes all the decisions. I'm the one who takes care of everything. And also hearing from the caregiver who said, why is the doctor asking me? She's in the room with me. She's right here. Talk to her. And I realized that while a health literacy practice is to encourage bringing of a friend or a family member to help you remember when you leave, to help remember and ask questions, that I don't think that there's guidance for healthcare professionals of how to incorporate those caregivers or friends and family members into the conversation, and thinking a little bit more about what we might be able to contribute to help that dynamic.
Yeah, thank you. Well, I am very grateful for all the comments that you all have made, because I too feel very satisfied with of the choices that we made. I too was on this committee, so we covered a lot. I also will say that one of the things I wanted to mention is the end of life part. That I would really like for us to be able to take that on at some time, because we had a lot to cover today, but we did not cover that, and that was by choice. But it really is an important element for us to think about. I think I'm going to choose to be like a one-note person from here on out. I've already told you all I'm all about like user-centered design, so I've said that a number of times. The other thing I'm going to say every time is value-based care and payment. And we've mentioned that a couple of times, But it just seems to me that this is a great opportunity for us to invest now in thinking about how to prepare the healthcare delivery system to be incorporating those elements of health literacy into their care delivery system, because they are going to have to be held accountable for keeping people healthy. And they don't know how to do that yet. For one thing, it can help us build a market for user-friendly tools, user-friendly conversations, for involving the community in with the healthcare delivery system. All the things that we have talked about many, many times really has a great focus, I believe, on caring for people, the older people. So I'm just hoping that we'll have a chance to come back to this sometime and revisit and perhaps contribute to, as a discussion paper or something that will help us help others kind of organize our thinking about that. The other thing I wanted to mention is the notion of self-advocacy and the connection between the care of older people and the people with disabilities. We mentioned that a couple of times, but helping people with disabilities understand how to be self-advocates seems to me a really important health literacy component. I'm familiar with people with disabilities and how they learn about being self-advocates from the very beginning. That's a part of learning about how to take care of yourself, and I think that's really a health literacy component as well. Kids with disabilities learn about that, and I think people who are older people need to learn about how to do that way, and it's a responsibility for healthcare organizations to include that. So I think those are the things I wanted to include, but I guess I wanted to say a special thank you to those colleagues who helped put this workshop together, because I learned a lot, and I really appreciate all the work that everyone put into this.
What was that? I'll give you a gem. Well, the gem is there. I think there's somebody's trying to tell me something, because I hear my hearing aid batteries telling me they're dying. So 5 o'clock in the afternoon, time to change the batteries. So one of the things that I was really happy to learn about was this village-to-village network, particularly because I didn't realize it was so formalized. I've heard of the concept, particularly in ethnic communities, South Asian, Southeast Asian, as well as LGBT communities, in terms of trying to figure out what they're doing as a community to take care of themselves later on, with varying degrees of success. So I was glad to see it included here, and to know that there are efforts that perhaps can be collaborated with on that front. And then thank you, Rima, for always providing some bits of wisdom. I'm looking at these death cafes right now. But the other thing related to villages, and the comment that was made earlier about cheers, about having the places where everyone knows your name. I think many of us get that reference. Those are the locations where we can communicate with each other and have the health conversations and the social connection and the literacy taking place. So thank you for that.
Thanks. I had a couple of thoughts as a nurse and informatician who does research with health disparate populations, particularly Latinos. One of the things is much of what we're talking about today ends up being what's called intersectionality, because we've been talking about where social determinants of health, health literacy end up intersecting with something like age and categories of the elderly. And I think that ends up being an important concept that puts people at increased disadvantage when all those factors come together. And so we need to be creative about our solutions. A number of the speakers, as well as Roundtable member Alicia, mentioned about the issue of the tech with the touch. And one of the things I wanted to mention is I've led a paper soon to be submitted from the National Institute for Minority and Health Disparities that's really been looking at technology-based interventions. And your gut is right. There is emerging strong evidence that at least in the area of behavioral change, that the efficacy is significantly increased when you have a human component in it. And so I think it's not one but the other, but figuring out how they work together. I had been hearing recently that sitting was the new smoking as far as the impact in health, but then I learned today that in fact social isolation is also the new smoking. And so we really have to think about it in terms of the elderly who may be sitting and being socially isolated. What I didn't hear as much about, we heard about apps and some other kinds of things, but not necessarily as much about other technologies. And it's very important in any of these things to match the user need and the context of their technology use to what technology you're using. And one of the things that is true is that that both Latinos and a higher portion of both Blacks and Latinos use Twitter more than do non-Hispanic whites. It's also a technology that's pretty well used by people who are older because of the similarity to text messaging. And so that's, pardon me? Yeah. It gets a bad name in that, but the point ends up being, well, he is, I don't know if he's a middle, I think he's middle old, not young old, but anyway. But I think we have to think about how some of these things work. And one of the areas that I do study is looking at Latino dementia caregiving, and we actually do study it on Twitter. And you'd think those caregivers might be too busy to tweet, but there is at least a quite big crowd that does, and we can learn very interesting things about both the content and the structure of caregiving from that. And we're really moving in our research to thinking much more, how can we take advantage of that to really think about different types of social support, including social support that is logistical in nature, as well as thinking about things that are more informational. Similar to some of the things that were said about some of the financing side and so much confusion about what to do, we find in our participatory design with the Latino dementia caregivers that is incredibly one of the most overwhelming things, is figuring out some of the financial logistics, and that along with some of the how-tos of dealing with some of the dementia symptoms.
Thank you again. This is my first roundtable, and I have to say I'm really impressed with the National Academy of bringing such a diverse group of people together and different backgrounds, and just really, I've learned so much today, so really, really grateful and happy to be here. I think really a lot of the key things have been covered, and I'm from pharma, I'm from Pfizer. I'm sorry, I'm from pharma. I work for Pfizer in New York, and I think Lori sort of really nicely summarized what I was sort of expecting to get out of here in terms of health disparities in clinical trials, what we can do around communicating information better about the medications we make, et cetera. But one thing that struck me is that I learned a lot, and I think that's about the role the community plays in helping bridge the gap. And another thing that struck me is that, you know, we're in the business of making medications that help prolong people's lives, and yet there's a piece where the elderly feel dismissed, and maybe our healthcare system is not really supporting the elderly the way it should be. So that's sort of like a takeaway from me in terms of what can we do around that. And then also another piece that Lisa touched on is the digital literacy and health literacy, and then access to healthcare. And that's something we have to really think about, because even though maybe our elderly are not really, maybe technology is not really being created in a way that the elderly population can really access it and use it, is that technology is here to stay, and how can we sort of like deal with that. And then on a personal note, it was really interesting for me because I was born in Uganda, I grew up in Cote d'Ivoire, and this whole community issues, like my dad was diplomat, now retired, lives in Uganda, and I never really have to worry about him in terms of who's there, or my parents who's there to take care of them, because there's this community, there's this sense of a village taking care of each other at every sort of like point in life. So I guess it's learnings then, looking at what we're doing here and saying, how can we incorporate, maybe using health literacy really, of making sure that from a young age, children realize that at every level, everyone is important. Because why is it that all of a sudden when people are older, they're sort of dismissed, and yet they still have a lot they can contribute. And also learnings from other countries. I think we touched a little bit on it, but I've been reading recently, I think it was in the BBC and New York Times, about what countries the UK is doing or Sweden is doing around this intergenerational mixing, where they have people in daycare going to living or being in the same building with seniors, and how it's really changed both groups of people. So how are we incorporating that in what we're doing here in the United States? How can we incorporate maybe learnings from other countries? And so I think that those are the few things that I take away, but really grateful for being here.
I think I'm feeling particularly incoherent today. Cognitive, perhaps. I hadn't thought of that as the explanation, but it may be. I do know that the day made me partly feel sad, and I think it was because I was remembering my parents, both my mother, who had been quite ill with dementia for the year before she died, and my father, who was the epitome of healthy aging and died following a fall or chasing a bus to go to a cultural event, and then had a pulmonary embolism. And I was thinking about also my patients who struggle with the issues of caring for their for their parents, and then my patients who are the parents, and the enormous, and then my patients, many of whom are home health workers. And I think what really struck me today that I wanted to take away is, one, that this is hard, even under the best of circumstances. But second, how much more we need to do to value plain work, the work of dressing and feeding and caring, and that no amount of technology is going to change that, and how this work is done overwhelmingly by women, overwhelmingly by immigrants, overwhelmingly by poorly paid people who are themselves struggling with lots of issues around intersection with knowledge and literacy and technology. And I think that it made me want to go away and see more about models in other places. And it also made me want to learn more about something very specific, which is, how is it that Medicaid came to pay for in-home supportive services. I don't know the story of that. And I feel that I need to learn the story of that to avoid feeling trapped into, okay, everything stays the same and we only have to change, we have to work on the technologic piece, or we have to work, but instead I need to learn how these big, big changes happened so as to avoid feeling that no matter what we do, women's work and the work of caring, that the touching will be devalued and very hard. So I really resonated, Ernestine, with what you said about the pressures our families and our communities are under, which makes it difficult to talk about better care.
I'm glad you didn't turn it off. Well, I think this was an amazing discussion. I want to tell you about an experiment that's going on in my family, and maybe it'll exemplify that all aging isn't the same. So I have 4 grandchildren from my oldest son, and they live very close to us, and they spend every Thursday afternoon from school till Friday morning when they go off to school at our house, because that's sleepover with grandma. And my wife has very advanced heart failure. She can, on a really good day, walk 2 blocks. And my 4 grandchildren, never having been told anything about her medical problems, never let her do anything. They won't let her pick up an envelope that she drops at home. If my grandson is being picked up by her at school, which is 2 blocks from our house, he has every single thing she was carrying, along with his knapsack, falling off of him because he won't let grandma carry anything. And all 4 of them know that. 5-year-old twins know it. They say, we never let grandma do anything. We clean the dishes up after she cooks dinner. They also have a grandmother who lives 10 blocks from them, who has significant early advanced dementia and is perfectly healthy. And they do not want to be anywhere near her. She does something about being with her they just do not like. My grandson Gavin will not be with her by himself. He'll only go if his older sister goes. And she is not advanced. If I introduced you to her, you would think she's still socially fine. But there is something about dementia that they don't get any good feeling about being with her. They don't get any good feeling about helping her. And they are very deeply uncomfortable when they're left alone with her. And so I will tell you, that has been reflected in my experience with family caregivers my entire career as a general internist. Family members with someone with dementia eventually get to the point where nothing they do makes them feel good anymore. And that is the opposite of someone dying at home with cancer, where everything they do makes them feel good. And so I think we need to understand that as we look at, health literacy, older adults, caregivers, even unto death at home, one patient is not like the other. And if we bundle them all into one lump, we will not actually progress in this discussion.
Thank you for allowing me to participate in this. It's been a great experience. Also wanted to thank for making the workshop accessible for me as well. So there were a few points that struck me, but also kind of reaffirmed the work that we still have to do. So this fragmentation of our healthcare system, how difficult it is for patients, providers to connect. There was a lot of talk about how ill-equipped providers are, and there seems to be sort of an emphasis on not only in their diagnostic, imaging, ordering, just kind of having that be the way to do differential diagnosis, and also how we treat our patients. So traditionally, we've kind of, from a primary care perspective, we've really talked about history taking being so vital, and there's a priority in making sure that you communicate well with a very mixed population. So we need to kind of go back to those roots to try to be able to work with our patients at a better level. The other thing that we've heard again and again, and some of you guys have already mentioned, is this village, is that we're a very social animal. We need that social connection. And without it, often there's social isolation. That's also very commonly seen with people with disabilities as well. So we need to find a way to stay connected on a deeper level. Now, technology can be a facilitator in some regards, but it also can be a barrier. We talked about superficial levels where, like Facebook, we're not getting in that depth there. The other thing is really important is this complex issue of this intersection that we see not only with health literacy, but looking at aging and also disabilities, race, ethnicity, social determinants. And so there's still a lot of work to do to kind of figure out how we can address them and also make sure that we include them in our future studies. The other thing is Cynthia mentioned about this, making sure that we prioritize and treating people who are most vulnerable. So digital divide, technology gives a lot of tools to continue to do better things, but some of those are vulnerable populations often fall behind. And so we need to make sure that we don't forget these people and find ways so we can get them included. Thank you.
Thanks. Hi, this is my first roundtable also, and I want to thank everyone for inviting me. It's been an amazing experience, and I think the program was great and got me to think about a lot of things I may not have thought about before. It also got me thinking about my mom, who's going to be 90, extremely active, but broke her leg last year, her first day of vacation in California. So now it's a new experience for her, and she's experiencing a lot of what we talked about today. She was used to being so active and so independent, and now she has to rely on others because it's her right leg, so we're not letting her drive. And she tells my sisters and I'm so lonely, I'm so lonely. And she's in an apartment down the street from her home where there's a community room, and she goes every day and she plays bingo and does puzzles. One of my sisters or her grandchildren visits her every day. We see her more now than we did before she broke her leg, but I think it's her loss of independence. And she's also told me what many of you have said here, well, I have this problem or that problem, and why don't you tell your doctor? I do, and well, what happens? They don't see me. I said, what do you mean they don't see me? I'm invisible. And I think that it's really sad because it's not necessarily that she doesn't have the health literacy to understand, but the doctor never gives her a chance because she's older and she's invisible to the doctor. So I think that we have to advocate for our old patients and family members. And when I went to the doctor with her, the doctor started talking to me, and I said, I'm here to help my mom, but please speak to her. She's very acutely aware of what's happening to her. And once the doctor started doing that, her recovery seemed so much more rapid, and she took ownership of it, and she was happy and not so lonely anymore. So it struck me, particularly when Ms. Zimmerman was speaking, that many of the problems about health literacy that we say the older patients experience are actually really quite similar to patients of all ages and maybe all diversities, but they're magnified and they're amplified, perhaps because they are invisible. And I think that the only way you can get someone to be not invisible is to make sure that they're active partners in sharing their healthcare decisions with their healthcare provider. And I think we need to figure out how to do that the best way. I think we still don't know how to do that. And also, as working at Pfizer, after coming from so many years in academia, it struck me that when I speak to a lot of my colleagues about health literacy, they say, oh, you're preaching to the choir. But what Dr. Thomas said really got me thinking, even the best choirs need to practice. And I think that maybe that's the gap that we need to actually fill and start with, that we don't practice enough and we don't really understand what it means to have this issue about health literacy. And when you drill down with many of the colleagues, they're really talking about low literacy, not health literacy. So maybe this whole choir needs to practice more and fill that gap.
I have the dubious distinction of being the last and maybe 27th, as Lori was mentioning, 27 or 28. So there have been so many wonderful comments already, and this workshop really resonated with a lot of people, especially in terms of their own personal experiences, either with going through their own health issues and trying to navigate the system, and which is very complex and difficult, and typically doesn't come to the patient. We have to stretch ourselves and make ourselves try to understand and navigate on our own in so many cases. Or they've dealt with, they've had to be a caregiver for a family member, and many of these stories, Anne Louise, your story really resonated with me and others, because my mother was diagnosed 5 years before she passed away with a terminal pulmonary disease, and her interactions with the healthcare system were so myriad and so different. And the best interactions were when physicians and nurses and pulmonary rehab specialists asked her what her desires were, what her needs were, what she wanted to be as the outcome, rather than just making the decision that, well, you're in your mid-70s, you are terminal. She had interstitial lung disease. There's no cure for you, and not even trying to help her, which was incredibly disappointing. And very impactful in terms of the family around here who were trying desperately to help her, because it made her so depressed. And plus the amount of medication that she was being given by all these different entities within the healthcare system, the way the interaction was like this poisonous river going through her body. And there was really not much interaction between the different specialists taking care of her. So I think we all have our personal stories. I think the very best interaction that she had with the healthcare system was the day before she passed away, when she went to I took her to the interstitial lung disease clinic at UCSF. And the physician there in charge of her case looked at her and took her hands and said, we can't cure you, but we can make you feel better, and we can give you quality of life, and we're here for you. And so I think that really, I learned a lot from that experience. It really helps me to be a better healthcare provider. So sorry about But I just want to get back to something Stephen Thomas said. I just loved his moral outrage. It reminded me of the first workshop I went to in 2012. It was the Oral Health Literacy Workshop when Elisha Cummings was there, also from Maryland. And he had that moral outrage because this 11-year-old boy, Diamante Driver, died of a preventable oral health dental disease that because the system let him down and let his family down, he ended up succumbing to an infection that started in a tooth. So I really appreciate his work at the community level, because I think when I think about ways to really level the playing field in terms of reducing health disparities, it really happens in the community. And I would just love it if the healthcare providers that go into the barbershops, that also there was a dentist or a hygienist included in that group of healthcare professionals. I think we have so much to add to in terms of chronic disease management, and it goes both ways. you know, if we want the medical community to carry our water, we need to do the same at the same time. So, but thank you. It was a great workshop.
So I must say we've gone through reflections by the workshop members for many years, and this probably is one of the most interesting ones that we've had. But I think a lot of it, as I was listening, was because of the personal reflections of the people around the room. The ability of those of us sitting here, to reflect on our own past experiences with aging and the sadness that sometimes leaves for us when those leave us. I hope that the proceedings of the workshop that we will have reflect some of this and doesn't just stick with the science and the details of facts that we came forth with today, because I think the personal feelings that we've expressed are as important. And in addition, it was interesting to see that as we began to talk about healthcare delivery, it was really the healthcare team we were talking about. There was no one individual who provides healthcare. It really is the team. And the team includes the patient, it includes the family, and it includes the community. And I think if we begin to think about that a little bit more seriously, we'll recognize that we can improve healthcare by team function rather than perhaps what we think about as a single caregiver, which really does not longer exist in the way we are learning to deliver healthcare. So this has been an extremely interesting day on a variety from a variety of perspectives. And once again, thanks for all your contributions. We will see you at 6:30 at The Bird. So we have an hour and 5 minutes, or 6 minutes. And look forward to continuing the conversation over a glass of water. Thank you all once again.